is Dr. Debasis Saha, Senior Consultant in Internal Medicine, Diabetes and Endocrinology, AMI Hospital, Salt Lake. Today we are going to talk on management of type 2 diabetes with fixed dose combination of linagliptin and empagliflozin. Now, type 2 diabetes is so prevalent that every 1 in 7 individual, you can take it for granted, is diabetic in our country. Just like every 1 in 3 individual is hypertensive in India. Now, regarding management of type 2 diabetes, you have to go for analyzing the etiopathogenetic aspect as has been illustrated by D. Franzo in the concept of ominous octet, like starting from beta cell secretory defect, insulin resistance, increased hepatic glucose output by the liver, increased lipolysis, cerebral fracture, achieving easy satiety with some sort of intervention like, delayed gastric emptying or interference with the intestinal absorption of the, I mean, just glucose molecule. So these are so many molecules, like even we can have that proximal convoluted tubular reabsorption site blockage by your gliflozins, just like your gliptins. Say, when gliptin was launched in our country in 2007 September, there came the idea that besides this, beta cell secretory defect, excessive hepatic glucose output, insulin resistance, there is some contribution from hyperglucagonemia. The glucagon is being secreted from delta cells of the islet of Langerhans. It has been already established that in diabetes population vis-a-vis your euglycemic population, there is, decreased incretin effect in the diabetic population. So whenever we are going to augment the patient's incretin system, either with the incretin mimetic or incretin enhancers, these sort of physiologic incretins which are having half-life of 2 to 3 minutes, it is being prolonged by the help of these incretin mimetics or enhancers. And we are very much privileged that now we have got this fixed dose combination of these incretin enhancers and empagliflozin. So the site of action, as illustrated by the difference of ominous octet, that site of action is something different between the two constituents of this fixed dose molecule, like the gliptin, which helps in more and more, insulin secretion beta cells of pancreas, which helps in easy satiety with a relatively lower amount of calories, which helps in, delayed gastric emptying. These are some of the effects in addition to neutralizing your hyperglucagonemia. Whereas the proximal convoluted tubular reabsorption of the excreted glucose, is being blocked with the gliflozin. Simplicity's sake, if we divide the type 2 diabetes population under two broad heading, one heading is, newly detected type 2 diabetes population, the other heading is type 2 diabetes population who are already on other OADs like glimepiride, gliclazide, pioglitazone, metformin, voglibus, etc. with, failure to achieve target HbA1c. Now I'm coming to the former group, that newly detected drug-naive type 2 diabetes population, where you see that HbA1c between 8.5 and 10.5% at the very first appearance of the patient in the consultant's clinic. The consultant has to be aggressive and intensive. He has to prescribe these fixed dose combination of empagliflozin and your gliptin, linagliptin. Why? The concept is no more glucocentric. The concept is cardio-renal centric. So you have to offer the cardio-renal centric benefit to the diabetes patient, because the concept is, again, I am telling you, it is glucocardio-centric continuum. So whenever the patient starts from euglycemic phase to IFG and IGT, it is the IFG and IGT stage where the coronary artery disease plaque formation starts. And this disease, coronary artery disease formation beginning, if you don't intervene in this stage with the aggressive means, the process will be fatal and fulminant. What has been already established as compared to the previously, you know, previous concepts, that, it takes at least 4 to 5 years for the patient to develop microvascular and macrovascular complication. No, it has been already established both in our real world data and all the trials that it takes hardly 1 to 1.5 to 2 years for the patient to develop microvascular complication and subsequently the macrovascular complication. So the aggressive intervention from day one can only help the patient. Not only the fact that it is aggressive and intensive intervention, there are some concepts like, say, the durability and sustainability of the treatment program. The treatment program with the glimepiride glycoside, which was there previous to the 2007, the patients used to lose their, target HbA1c achieved after 4 to 5 years down the line post prescription. Whereas what we are finding nowadays, that 2007 September when gliptin was launched in our country, and 2010, 2010-11 when gliflozin was launched in our country, what we are seeing, they are offering long-term sustainability and durability treatment program. The same molecule with the same dose which were prescribed those days, 2007, 2008, patients are still maintaining their target HbA1c, fasting blood sugar, PP blood sugar, and random blood sugar, so to say, 8 SMBG. So this is known as, long-term sustainable durable treatment program, so that adherence to the treatment program is more firm, more prolonged, so that you can avoid macrovascular complication. Not only that, there are certain terminologies that avoidance of wide diurnal glycemic variability, more and more, adherence to time in range and improvement of better quality of life. All these three criteria, say, for example, peak and trough, avoidance of wide diurnal glycemic variability, which is very much common in the patients prescribed with the glimepiride glycoside, along with other combination like voglibos, pioglitazone, metformin. But these gliptin and or gliflozin, either in single stage or say combination, I mean, these are the cases where peak and trough situation is not prevailing, where there is long-term sustainability of the treatment program and more adherence to time in range means 17 hours a day. The patient's blood sugar should be between 70 and 180 mg per dl. So, considering all these factors, that these three basic requisites, avoidance of wide glycemic variability, more and more adherence to time in range, improvement of better quality of life, say for example, NIHA class 4. So what I'm talking about, that we can offer any anti-hyperglycemic molecule which has got this sort of, wide long-term sustainability, durability of the treatment program, along with the avoidance of weight gain and hypoglycemic spell. Because all of you know, weight gain means more and more insulin resistance. So there is failure to achieve the target, and your hypoglycemic spell, because one hypoglycemic spell will make the patient divergent from the treatment program, as a result of which patient has to get more and more microvascular complication. And now I'm coming to the second subset of the diabetes patient. Type 2 diabetes who was being treated with those sort of glimepiride glycoside along with the plus minus pioglitazone metformin. On the contrary, they have not achieved the target HbA1c. These are the patients where even 8.5 to 10.5 HbA1c, you have to go for triple drug therapy from the beginning. Means metformin in addition to this empalina fixed dose combination. Now I'm coming to third point, that patients who are insulinized, like your insulin, say basal 2 plus or basal bolus insulin, whenever you are putting these patients on impalina combination or only impa or lina, the total insulin dose requirement becomes, 10 to 15% lesser. So these are some of the advantages, that you are hitting the nail at the right point. You are helping the patient for recreation of the atherosclerotic plaque, because already it has been established that these sort of incretin based therapies, they help in regression of the atherosclerotic plaque volume. As I can tell one story, real story, that when liraglutide was launched, prior to the launch, dog's LAD was occluded with a gel embolization, and that dog's myocardium, which has been infarcted as a result of LAD occlusion. Linagliptin was injected, and it was found that amongst the whole mass of the necrotic myocardium, the some amount, I mean at least two-thirds of the myocardium, it became viable. So this is hibernating myocardium. I mean viable myocardium. These are the concepts with the your gliptin therapy, whether they are incretin mimetics or incretin enhancers. So what we are doing, we are helping in regression of the atherosclerotic plaque volume. I'm quoting from my own real world data. It has been already established by, say, carotid intima media study by carotid Doppler that there is regression of this atheromatous plaque volume, and you can extrapolate this data to the coronary artery disease both from qualitative and quantitative point of view. So, on the whole, I can talk about the fact that these are the novel combination in contrary to the previously existing antihyperglycemic molecule like glimepiride, gliclazide, or pioglitazone voglibose, that you are making the patient achieve target H1C within very first 3 months of the administration of the particular drug. And I'm quoting from my real world data. I don't have any single case failure. There is no single spell of hypoglycemia. There is no weight gain, and thereby you are breaking, rather, you are hitting the nail at the right point in the cardiovascular continuum, in the cardiorenal continuum, in the cardiorenal glucocentric continuum, so that the patient enjoys a better quality and quantity of life. And that's all about today's talk. Thank you.